है, बच्चे का पीलिया भी कम हो चुका है। अब इसका लाइट भी बंद कर दिया गया है, बच्चे को भी नीचे भेज दिया जाएगा। ये बताइए, माँ का टीका लगा है बच्चे को? पहला टीका
Dr. Maurya, please mute yourself.
लगा है, ठीक है।
So good afternoon, everybody, and very warm welcome to this e-learning series, which we are doing for mainly our PG students. Main focus is towards that, so that we can just brush up our knowledge about the basics of the pediatric cardiology. And today the turn is for the electrophysiology. It is ECG, and the panelists are Dr. Rakesh Bhatia. Sir is the senior pediatrician in Agra, and Sir is like when he starts speaking, you just keep on listening to him. He's such a good orator, and no one can be better to make this ECG type topic more interesting when Mani is speaking and Sir is the panelist. And Mridul is in Gangaram, a senior pediatric cardiologist. He's also having a keen interest in electrophysiology and the imaging. So both our speaker and the panelists are more focused towards the imaging and the electrophysiology, and Sir is there to balance the situation. So over to you, Sir. And Sir, please introduce Mani, and then we can start the presentation.
My turn?
Yes, sir.
Okay. I'm so delighted to be a panelist for this wonderful session. Over the years, with the easy accessibility and availability of the echocardiography, the ECG seems to have taken a backseat, especially for the general pediatricians. I remember when our student days, we used to pour over the ECG strips during our rounds and during our panel discussions and during our class discussions. But unfortunately, this doesn't happen anymore. We tend to rely much more on the echocardiography report, and this is the need of the hour. And I'm so glad Dr. Manish has kept this wonderful topic for our postgraduate student and also for our general pediatrician who need to remember that ECG as an equally important investigative tool as far as the managing pediatric cardiac disease is concerned. And so happy that we have someone like Dr. Maniram as our speaker today. He's, I'm sure, very passionate about the ECG itself because his field of specialization seems to be acquired and inherited cardiac arrhythmias. So delighted to have you here as our main speaker. I'm sure we're going to benefit a great deal from all the deliberations today in this session. Dr. Maniram is an eminent pediatric cardiologist in the country, trained in Australia, has written a large number of papers in national and international journals, and also has contributed chapters to the many pediatric cardiology textbooks. He's passionate about ECG, and we're going to listen to him about the various aspects of the pediatric ECG. Now, pediatric ECG is not an easy cup of tea for anyone, especially for general pediatricians. And I'm sure all of you are going to listen with rapt attention to what Dr. Maniram is going to say. Dr. Maniram, please.
Thank you, sir. Thank you for the kind words of introduction. I've actually divided this talk into two parts. So depending on how time goes, because I think the basics of the ECG is very important. So I think it is perfectly acceptable to go very slow so that all of you get a good understanding. And even if the second part is not possible today, we can always do it some other time. So I call this, like as sir said, the ECG has probably sort of taken a backseat to echocardiogram in the diagnosis of congenital heart disease. And that is perfectly acceptable because, ECG is not a very sensitive tool for diagnosing congenital heart disease. But ECG has a lot of importance in various other aspects, okay, like diagnosis of arrhythmias, treatment of arrhythmias, as well as, follow-up of certain conditions. So while it may not be as important as it was for diagnosis of congenital heart disease, it is extremely important in the diagnosis and management of arrhythmias. And for that reason, it is important that a pediatrician is very familiar with the ECG. I'm going to call this talk as demystifying the ECG because unlike our adult colleagues, we get very tensed while seeing an ECG. So these are not symptoms which a child has when he or she has somebody is not muted. So these are actually the symptoms.
Mute everyone else. I think you can mute everyone else.
कश्मीर में अभी तो पहले एंगेजमेंट में निकाह करते हैं, फिर रुखसती।
So I would say these are not the symptoms of a child with palpitation. These are actually the symptoms which we as a pediatrician or a pediatric PG, we feel when we see an ECG during in the emergency room, right? Because we only see a few arrhythmias, a few abnormal ECGs per year during our training. Whereas adult colleagues, they see abnormal ECGs day in and day out, and they are more comfortable interpreting and acting upon an ECG than we are. So what I want you to take from today's talk are systematic evaluation of an ECG, recognizing whether an ECG is normal or abnormal, and then once you decide it's abnormal, to go ahead and try to identify what the abnormality is. And to some extent, what to do in an emergency situation before you refer the child. Now, ECG reading, do you think it's an art or a science? Now, if I ask you to tell me what is next in this question mark, all of you will immediately say, it is the green square. But if we give you this pattern and ask you what is next, you're not going to answer immediately. You're going to take some time, but I'm sure all of you will get the answer right. So the first question you were able to say within seconds, but the second question took slightly longer. It is the same thing with the ECG. When you start out, it has to be a science. You need to systematically interpret the ECG so that you don't make any mistakes. But once you have interpreted an enough number of ECGs and you become more comfortable with reading the ECGs, then it becomes an art. As soon as you look at an ECG, you'll be able to make the diagnosis within seconds. So yes, it is both a science as well as an art. When you are less comfortable, you have to follow a rigorous scientific protocol in interpreting the ECG. But once you become more comfortable with the ECG, you should be able to diagnose the condition much quickly. So it's all about pattern recognition, ECG. And unless you repeatedly see the patterns, you will not recognize the patterns. So to recognize the pattern, you have to see the pattern. And to see the pattern, you have to take ECGs and try systematically reporting them. Okay. The first question is recognizing a serious cardiac rhythm problem. So this is actually an 11-month-old child with hydrocephalus and significant developmental delay who was admitted with recurrent episodes of vomiting and dystonic posturing, noted to have a high heart rate during that posturing, and the rhythm was interpreted to be a VT. The baby was otherwise hemodynamically stable. There was no perfusion problem acutely. And this was the ECG which was recorded during the monitor when the child was admitted. Now, how many of you think that this ECG is abnormal? You can maybe, write a note in the chat box. All I want you to say is yes if you think there's an abnormality and no if you think this is normal. So I'm going to show some of the strips which were recorded.
You all can write in chat box.
Now, I don't want interpretations. All I want is, whether this is, yes, there is an abnormality or no, there is no abnormality. Just yes or no. Abnormal. Okay. I'll give maybe another 10, 15 seconds and then. So all of you who have more than 5 people have replied, everyone has said this is abnormal. Okay. So if you look very carefully at the ECGs, I'll go back to this film. So you can see that there is a normal sinus rhythm, and then you can see there is a very bizarre rhythm, right? All of you will agree with it, correct? So that is what made you think that this might be an abnormality. And that is what made the monitor also think that this is ventricular tachycardia. But this monitor has two parts. It has a it has an ECG part at the top. It also has a plethysmograph at the bottom from the saturation. And if you look very carefully, you can see that the pleth remains totally stable throughout all of this. Okay. If you are having such a fast heart rate, can the plethysmograph show a totally normal tracing? Is it possible? No, it's not possible, right? So what happened here was this child had dystonic posturing. Okay. So there were a lot of artifacts on the ECG, which to some extent mimicked the ventricular fibrillation. Now, again, a very common point. This child did not have any hemodynamic instability during any of that events. So whenever you have ventricular tachycardia, it is a very abnormal rhythm, and you would expect the child to be hemodynamic unstable. This was not the case. Okay. And if somebody had the presence of mind to check the pulse at the time, the pulse would have been completely normal. Okay. So before we rush into interpreting an ECG, it is always important that you interpret it in the context of the patient before you. Okay. You might have a very wide complex rhythm, but if the heart rate is only 90, there is no tachycardia at all. So you don't have to think about ventricular tachycardia. Okay. If this child's ECG shows a ventricular rhythm with a heart rate of more than 300 and the pulse is very good volume and only 100 per minute, then you know you're missing something. Okay. So before you rush to interpret the ECG, you remember that you only have to do it in the context of the clinical patient in front of you. So even though, at first sight, you think there's an important rhythm problem in the hands of this patient, actually this child does not have a heart problem at all. Okay. So, so that is the first thing which I want. Or if you are taking back only one thing from this presentation, this is what I want you to do. Don't interpret an ECG in isolation. Interpret it in the context of the patient who is in front of you. Okay. So, do the basics. Make sure you check the pulse, the perfusion, the blood pressure before you go into treating an arrhythmia. Okay. So we all know about the 8-Owens triangle. We all know where to place the leads and which are the limb leads and which are the chest leads. I'm not going to bore you with all of that in today's talk. I'm going to go to interpretation of ECG. And the first thing before you start interpreting ECG is to have a checklist for every ECG which you interpret. The first thing which you need to check in the ECG is the tracing standardized and of good quality? How many of you know about standardization of the ECG tracing? Just yes or no answer in the chat box. I'm going to go into each of the points in the checklist during my next few slides. I'll first present the checklist and then we will go into the individual components of the checklist. Able to use the chat box one. Sorry, I'm unable to button mouse. So, okay, so then once you check the standardization, the next thing is to check the heart rate. The next is whether the rhythm is sinus or not. And for that, the rule is, there are only two rules. There has to be a P wave before every QRS complex, and the PR interval needs to be constant. So these are the two rules for the rhythm being sinus. The next is to check the PR interval. I'm going to show all of this in the next few slides. Next is to look at the QRS complexes, see if they are normal or abnormal. Then this may not be very important in pediatrics. STT segment changes. This is probably the most important part of interpreting an adult ECG. But in most of your pediatric patients, this may not be very important. But sometimes you do need to check if there is a repolarization abnormality, see if the ST segment is normal or abnormal. So, and the last is, which I've probably not added, just to keep it simple, is to calculate the QTC interval. So that is my checklist for any ECG. First, check the standardization, see if the heart rate is normal or abnormal, see if the rhythm is sinus or not sinus. If it is sinus, look at the PR interval, then look at the QRS complexes and see if they are narrow or wide, and look for repolarization abnormalities, including ST-T segment changes and for abnormal QT intervals. So whenever, like many of you would always, most of us are very religious, and we will always, some of us start any activity by invoking God before we go into the activity. There is something very similar in interpretation of ECG as well. So in Tamil, we call it Pillayar Sudi. You might have an equivalent term for it in Hindi as well. But for the first thing to do whenever you interpret an ECG is to check for the standardization. Every single one of the measurements you make, including the heart rate, the PR interval, the QRS duration, and ST segment changes, are invalid if the standardization is not correct. So how do you check for standardization in an ECG? Depending on the machine you have, there are multiple ways, but most of them are reasonably similar only. So the first thing which we look for is, there will be a standardization a rectangle. So in some machines, it will be at the start of the ECG. In some machines, it will be at the end of the ECG. But almost all machines will have this rectangle of standardization. This rectangle should be 10 small boxes or 2 large boxes in height, and 5 small boxes or 1 large box in diameter. So if that is the case, then the ECG is of normal standardization. Most advanced machines will also have it depicted in writing either at the bottom or at the top of the ECG. So the standard speed, which is the x-axis along this ECG graph, is 25 millimeters per second, and the standard amplitude, which is the y-axis along the ECG graph, is 10 millimeter per millivolts. In certain situations, we might use 50 millimeter per second or even 12.5 millimeter per second. In certain situations, we will also use 20 millimeter per millivolt or 5 millimeter per millivolt. But most of the common formulas which we use are for this standardization. So always check the standardization before you go into interpreting the ECG. So either by using the standardization rectangle or by reading out what is printed at the bottom of the ECG chart. So the speed is 25 millimeter per second and the amplitude is 10 millimeter per millivolt. So only if this is satisfied, whatever we do next will be correct. The next thing is calculating the heart rate. So in MBBS, we are always taught 300 divided by number of large square is the heart rate. That is reasonably okay for an adult population, where the normal heart rate range is between 60 to 100, where anything below 60 is abnormal and anything above 100 is abnormal. But that is not the case in a child. So for example, in a neonate, even a heart rate of 200 while crying is normal. In an older child, say an 8 or 9-year-old, a heart rate of 120 may be normal at rest, may not be very abnormal at rest. So you have a much wider range of heart rate, and it is important to be more accurate while identifying the heart rate. So you cannot go by 300 by number of large squares. You need to use 1500 divided by number of small squares, which will give you a more exact interpretation of the heart rate in pediatrics. So this is the cheat code in adults. Unfortunately, it doesn't apply in pediatrics. You need to take out your calculator. You need to check the number of small squares and divide 1500 by the number of small squares. So I'm going to give some exercises. All of you are going to look at your screen, calculate the heart rate, and write it in the chat box. So here, what is the heart rate in this ECG? Oops.
And
I know it's a post-lunch session, but still I'm sure we should be able to put up a small effort and try to calculate the heart rate.
1, 2, 3, 4, 5, 6.
So I got a few answers saying 75, which I think is close to the correct answer. But unfortunately, I think most of them have used the 300 divided by number of large squares rule. So you can see that, it is slightly less than 4 large squares here. So it doesn't complete 4 large squares if you look at this example. So as I said, you need to look at the number of small squares. Yes, on a webinar, it's slightly more difficult to look at your screen and look at the number of small squares. So I think it is acceptable. But if you look very carefully, it's actually, sort of 18 small squares between two QRS complexes. So the heart rate is 1500 divided by 18, which is 83 per minute. So 75 and 90 are the common answers which I've got. I think because this is online, I think this is acceptable because it's very difficult to look at the number of small squares. So next one. So what do you think is the heart rate?
Mm, 3, 6, 7, 8, 9, 10, 12, 13, 14, 15, 16, 17, 19, 20, 21,
I'm not getting
24,
any
25,
answers.
26, 27, 28, 29,
Wait for another
30,
20
31, 32. 32.
So we got 45, 68.
45, 68. I think Anju Singla has used these two QRS complexes, which are the closest to get the rate of 68. I think that is an aberrant one. Most of the other ones are reasonably constant. So I've used these two, and the number of small squares is actually 35. So the heart rate is roughly 43 per minute, which is 1500 divided by 35. So if you had used this particular one, it's going to be slightly higher. But most of these QRS complexes are approximately 7 large squares or 35 small squares, which gives a rate of 43 per minute. So we have looked at one slow heart rate, we have looked at one near normal heart rate, we have got one fast heart rate here. So can you all calculate the heart rate now? And this time, unfortunately, it is much less than 2 small squares. You cannot use the 300 divided by large squares option.
Be quick. 211. You got one answer.
1, 2, 3, 4, 5, 6.
So I got answers ranging from 185 to 210. So essentially, there are 8 small squares between two QRS complexes, and the heart rate is 188 or 187, depending on where you want to stop the fractions. So yeah, most of you, I think, have got this right. I hope you have got a hang of calculating heart rate because that's the first and most important step in interpreting an ECG. Yeah. The next is to check whether the rhythm is sinus or not. So what is sinus rhythm? So sinus rhythm is any rhythm which originates in the sinus node, which is in the right atrium, passes along the atria, depolarizing the atria, comes to the AV node, passes through the AV node from the atrium to the ventricles, and then spreads across both the ventricles through the bundle branches, depolarizing the ventricle. So it starts at the top of the right atrium, traverses the right atrium to the AV node, and through the AV node enters both the ventricles. So the initial activity is ventricular atrial depolarization, which is represented by a P wave. So from the sinus node, it has to cross the AV node before entering the ventricles. So the interval from the start of the P wave to the start of the QRS complex represents the time taken for the impulse to traverse the atrium, the AV node, and then reach the ventricle. So for sinus rhythm, it has to originate from the top of the right atrium. The P wave and the PR interval should remain constant. How do you know if the impulse starts from the top of the right atrium or not? So it's very simple. as we've got this diagram of the impulse on the left side. So it has to travel downward and towards the right side of the screen, right? So this is what you expect the impulse to travel downwards and to the right of the screen. So we take the 90-degree perpendicular axis, which are leads 1 and AVF. And if you look at this vector, it is in the positive quadrant of both 1 and AVF. Does this make sense to everyone? So you have the impulse traveling here in the cartoon on the left, and you can plot it on the graph chart on the right. So does this make sense to everyone? Yes or no? I like to see some answers because this is an important concept before going ahead. We need to use the same rules for access as well. So yeah, so many of you have answered yes. So yes. So I would expect the P wave to be positive both in lead 1 and ABF if it is starting from the sinus node. So the rules for sinus rhythm, the rule number 1 is that every QRS complex should be preceded by a P wave. So we will use the rhythm strip here. You can see there's a QRS preceded by a P wave, QRS preceded by a P wave, QRS preceded by a P wave, QRS preceded by a P wave. So every QRS is preceded by a P wave, but that is not enough to say that the rhythm is sinus. The next thing is you have to see if it is positive in both lead 1 as well as in lead AVF. So both in lead 1 as well as in lead AVF, the P wave has a positive deflection. So this is indeed sinus rhythm. Do all of you agree with that? Yeah. So unfortunately in pediatrics, it's not as simple as in adults, okay? Sometimes you can have abnormal hearts where the entire situs is shifted. So situs inversus and dextrocardia, okay? So in these conditions, the right atrium is on the left side and the left atrium is on the right side. And the SA node is actually on the top left corner. So again, if you plot the direction of the depolarization vector on the graph, you will see that it comes in the positive quadrant of AVF, but in the negative quadrant of lead 1. Okay. So in situs inversus dextrocardia, yes, every P wave will be preceded by every QRS complex will be preceded by a P wave. But unfortunately, the P wave will be negative in lead 1 and positive in AVF. So you need to know the situs of the patient before interpreting whether it is sinus rhythm or not. If you go by my rule that lead 1 and AVF are positive, then you will think that this is not sinus rhythm. But unfortunately, this is a patient who has situs inversus and dextrocardia. But again, if we had done a proper clinical examination before we do the ECG, we would have known that the cardiac impulse is actually not on the left side, but on the right side. So again, you have to interpret the ECG in the setting of the patient in front of you. So in situs inversus dextrocardia, AVF will still be positive, but lead 1 will be negative. The next thing is to calculate the PR interval. So as I mentioned, PR interval is the time it takes for the impulse to travel from the SA node to the ventricles. So this involves conduction through the SA node, through the atria, through the atrioventricular node, and the proximal His bundle. Okay, so all of this represents the PR interval. But as you can see in this cartoon here, the bulk of the PR interval is by the atrial conduction and the AV node. Everything else only involves a very small segment. So essentially, the PR interval is an indicator of the health of the atria as well as the AV node. So how do you calculate the PR interval? You need to count the number of small squares from the start of the P wave to the start of the QRS complex. So even though traditionally we call it the PR interval, In reality, it is actually only a PQ interval. It's not a PR interval. So it needs to be from the start of the P wave to the start of the QRS complex. You count the number of small squares and multiply it by 40. That will give you the PR interval in milliseconds. Does that make sense to everyone? I need to have an yes or no because I'm going to give you some more exercises again. Okay. So after this, you're going to interpret a few PR intervals.
Yes, there are few yes there.
There are a few yes. I'll take that as a yes. And then I'm going to ask you guys to calculate the PR interval here. Unfortunately, there is no shortcut to getting good at ECGs without systematically interpreting them. So it's important that you do all these problem solving. It's not something which you watch on the screen and then go back and do immediately. Somebody has written 0.16 or 0.16. Sorry, I missed the point. So I'm getting two different answers, 160 milliseconds and 120 milliseconds. No, I'll probably take this PR interval because it's at the start of a large square, making it easy to interpret. So you can see that it is not extending up to the fourth space. So as I mentioned, the PR interval is still the start of the QRS complex. So the QRS complex actually starts here, whereas the P wave is here. So it is definitely much less than 4 small squares. It's actually 120 milliseconds and not 160 milliseconds. Okay. Okay, this one. I'm really happy that so many of you are actually attempting this. ECG is, at least for a pediatrician, a slightly boring topic, and this is a Sunday afternoon, so I'm really impressed, honestly.
The two answers, 280,
280 milliseconds. No, this is definitely not. Say, I'll take this one. It's definitely not crossing one large square, right? So it cannot be 280 milliseconds. Somebody has usually written 360. So I don't know if you mistook this for the P wave. I think that is what has happened, is it? But then it's much stronger. So this is the start of the P wave and this is the start of the QRS. You can see that this distance is lesser than one large square. So it cannot be more than 200 milliseconds. 160 is the right answer. Okay. So once you have done the heart rate, checked whether it's sinus or not, and the PR interval, the next important thing is to calculate the QRS axis. For axis, we divide it into 4 quadrants. Okay. So ideally, as a cardiologist, Munish ma'am will not accept 4 quadrants. So they want more specific degree. But I think for a pediatrician, sticking to quadrants is good enough. Okay. And to find out the quadrant in which the QRS axis is there, you need to look at only 2 leads. You need to look at lead 1 and you need to look at lead AVF. Okay. If the QRS complex is predominantly positive in both those leads, then the axis is normal. Okay. So again, I think you just have to use the same chart which I used here. Okay. If it is lead 1 and AVF both are positive, that is a normal axis. Okay. This is the rule which we use. So if both lead 1 and AVF are positive, it is normal axis. If lead 1 is negative and AVF is positive, it is rightward axis. If lead 1 is positive but AVF is negative, it is leftward axis. And if both are negative, we call that as a northwest axis, which is not a very common axis. Okay. So I think when I show examples, it will make more sense. So both lead 1 and AVF are positive. This is normal axis. If AVF is negative but lead 1 is positive, you can see that the axis has moved from here to here, which is more leftward. So if you keep your hand here and move it this way, it is actually moving leftward, right? So that is what is left axis deviation. If AVF is positive but lead 1 is negative, then it has moved more rightward, which is right axis deviation. And if both are negative, it is northwest axis. Okay. So why do you need to know about axis? Why is it so important to know about axis as a pediatrician? It is probably, compared to your adult colleagues, it's probably slightly less important, but still it is something which you need to know because it might give you a clue about heart diseases even if you don't have access to echocardiograms. So we told you about normal axis. That is what you expect in any normal person. But in a neonate or in a young infant, right axis deviation is actually normal. Okay. So if you have right axis deviation in a neonate or a young infant, that is perfectly normal. You don't have to think about a heart disease. Whereas if you see right axis deviation in an older child, say an adolescent, then you need to consider the possibility of a heart disease. But if you see left axis deviation, almost always it is abnormal. So there might be an underlying heart disease which we are missing, and it is important that you go and look for it. Okay? And even if you have normal axis, sometimes that might be abnormal in a newborn in the first few days of life. So you expect a right axis. So even a normal axis is more leftward than normal. So by looking at the axis, you might get some important clues to a heart disease if you don't have access to an echocardiogram immediately. So again, we are going to exercise our brains here. So what is the axis?
Look at 1 and AVF and please type your answer quick.
So many of you have typed normal. So again, I actually put this as a first instance to actually make it slightly complicated. All of you will agree 1 is positive, right? I think all of us will agree 1 is positive. But look at the AVF. Is it really positive? The R wave and the S wave are almost the same, right? Or maybe the S wave is slightly longer than the R wave. Okay. It may not be apparent at first glance, but if you look very carefully, the positive deflection is probably only around 8 small squares, whereas the negative deflection is close to 10 small squares. So actually, this is left axis deviation. This is not normal axis, okay? 1 is positive, yes. At first glance, the AVF may look to be positive, but if you look very carefully, it is equiphasic or actually slightly negative. So this is not normal axis, this is left axis.
Ali has
What
written.
about this one?
Quick, just do in second because this is picture reading.
So yeah, again, good. Both are negative, okay? So AVF is very clearly negative, no doubts about that. But if you look closely at lead 1, the negative deflection is definitely larger than the positive deflection. So if both are negative, what do you call it? You call it northwest axis. So somebody had written both negative right axis. Actually, even in northwest axis, sometimes we have to make a differentiation between a leftward axis or a rightward axis. So it can represent either extreme right axis or extreme left axis. I did not go into that, just to keep it simple for you. But because somebody had mentioned right axis, you can see here that lead 3 is negative, but AVL is positive. So in this particular case, yes, it is northwest axis, but it's actually extreme left axis deviation and not right axis deviation. Okay. I mean, again, I don't want to confuse you. I'm happy that most of you got it as northwest, and that is all is what is expected of you. Okay. Last one before we go. What is the axis? This is relatively simple. I'm sure all of you will get it right. Because all of you got northwest right, so this is much, much simpler. So I'll give you a minute and then we'll move on. So here you can see that one is definitely negative and AVF is positive. So if one is negative and AVF positive, this is right axis deviation. So I think all of you have mastered axis, rate, PR interval, and sinus rhythm. Very good. So before I go to the next part, is this normal or abnormal in a neonate? So we'll stick to axis for now. We won't go into all of the parts of it. So somebody has written negative, positive, right? So yes, lead one is slightly negative and AVF is positive. So this is actually right axis deviation. But as we have mentioned already, in a neonate, right axis deviation is actually normal. So yes, there is right axis deviation, but still it is normal for a neonate. Okay, all of you have got it right. Very good. What about this? So yes, all of you type left axis. Is this normal or abnormal for an neonate? So this is definitely abnormal. Okay, if you see left axis, then it is very likely that this child has an important congenital heart disease. So you don't have to make an exact diagnosis based on the ECG, but this is shouting out loud to you that there is something wrong with the heart. You need to get this baby evaluated immediately. So how does the axis help in diagnosis? Again, I think it is very difficult to make a diagnosis of congenital heart disease based only on the axis in an ECG. Yes, it might give a clue, but it is not the only indicator. So, I will ask you to use all of these for your exams because all of these can be MCQs in the exam. But in the real world, as Sir pointed out, you cannot make an absolute diagnosis of a particular congenital heart disease just based on axis. You need to get an echocardiogram. But again, as postgraduates, it's important that we pass our exams as well. And it's important that you know all of these, okay? So tricuspid atresia, there'll be left axis deviation. Inlet VSDs, there'll be left axis deviation. Complete AV canal defect, you can have either left axis deviation or even a northwest axis. Tetralogy of Fallot usually has a right axis deviation, and congenital rubella syndrome can have left axis or normal axis in a newborn. So Noonan syndrome, especially certain varieties of Noonan syndrome, like a condition called Noonan syndrome with multiple lentigynes, and congenital rubella syndrome can have a left axis deviation even in the newborn period. So these are the things which we look for in the in the ECGs. And what I want from you is first to keep looking at ECGs. Okay, unless you keep looking at ECGs, you will never master ECGs. So the key to master ECG is to keep looking at ECGs. That is the first thing which I expect out of you. Always interpret the ECG in the context of the patient you have in front of you. So even if the child has a tachyarrhythmia and is looking a bit sick, always spend a short period at least to get a brief history, because that will give you very important information as to how quickly you need to manage this child. Examine the patient thoroughly before you go into interpreting the ECG. And even, none of us are experts CCGs. All of us, even Munish ma'am and I, have gone through the same phases which you went through. As a pediatrician, we were not at all comfortable in interpreting ECGs and making decisions based on ECGs. So it is okay not to know how to interpret ECGs, but all of us have smartphones now. So whenever you have an abnormal ECG and you're not able to interpret it correctly at that point of time, take photographs, keep it, discuss it with people who who are experts in it, and learn from that so that you don't make the same mistake the next time as well. And always stay curious. Okay, you cannot become a master at ECG unless you remain curious all the time. Okay, so preserve and discuss the ECGs whenever the opportunity is available. And with the advent of WhatsApp, it has become very easy. Experts are available, just at the touch of a button. You can just take a good quality photograph and send it and get an answer almost immediately. I hope it has not been too boring, and I'm happy to stop here and answer all your questions because I want you to understand the basics very well. But if there is time, I can go into the basics of arrhythmias as well. So I think I will take questions now, ma'am, if that is okay. And if time permits, go slightly deeper. So I've stuck to just the very basics for the first part.
There was this one question about Ali was someone was asking about how to get P wave access. Just to repeat that.
So the P wave axis, again, it's the same rule as the QRS axis. Okay, so you need to look at leads 1 and AVF, and if it is so again, so you need to look at degrees in the P wave. It might be a slightly more confusing part, but to look at the P wave axis, again, same two leads, lead 1 and AVF. And if it is positive in both, that means you're in normal axis. Okay. You can also have left axis deviation and right axis deviation. Now, what information this gives you, the P wave axis, is where it originates from the atria. So I'll go back to that cartoon I have here. So again, if you see, the AV node is in the top right-hand corner, okay? And the impulse from the AV node traverses like this. So if it does that, it will be positive both in lead 1 and AVF, okay? Supposing you have a rhythm which starts from the bottom of the right atrium, okay? It will be traveling in this direction to both the atria. So it will be positive in lead 1, but negative in AVF. So if you have a rhythm where it is negative in AVF, but positive in 1, that tells you that the rhythm is originating from the inferior portion of the atrium. Okay. So and supposing it starts from the left atrium, it has to travel in this direction. So it will be negative in lead 1, but positive in lead AVF. So if you see an ECG where there is essentially a right axis deviation, it is negative in lead 1 and positive in AVF, that tells you that it is originating from the left atrium and not from the right atrium. So the P axis tells you where the atrial impulse is originating from. If it is from the sinus node, it will be positive in 1 and AVF. If it is from somewhere in the left atrium, it will be negative in lead 1, but positive in AVF. And if it is from the inferior portion of the atria, it will be positive in lead 1, but negative in AVF. That answer your question? Does it make sense?
That was very fascinating. Such a simplified presentation for the electrocardiogram interpretation. I think all the PGs must have benefited a great deal, and also the general pediatricians who are there in the audience. Uh, Let me emphasize that it's not only for the primarily cardiac lesions that the ECG is useful. There's so many other non-cardiac situations where ECGs are of great utility, especially in the management of the electrolyte abnormalities, especially like hypokalemia or hypokalemia and other conditions where there are associated electrolyte abnormalities, or conditions like Kawasaki disease where cardiac lesions are an important component. So there might not be a primarily cardiac lesions, but they're still very useful for the general pediatrician and the pediatric resident. So very nicely and very simplified presentation of the electrocardiographic studies. And I think the practice is the key. What you have so rightly emphasized, that you keep on looking them, it seems to become much simpler, not as daunting as it seems in the beginning when you start looking at the ECG tracing. I think there are more questions in the chat box.
I request Madhur also to give some comment.
Yes, sir. Just wanted to add this minor thing that suppose we had a irregular beat ECG was there that Dr. Mani has shown. In that case, if we have a proper 12 leads rhythm strip, which is usually of 10 seconds, so we can calculate the total number of beats in that 10 second and simply multiply by 6. So whenever there is a irregular rhythm and we have standard 12 lead ECGs there, so whole strip at 25 speed is of 25 of 10 second. So if you want to calculate the ventricular beat, we can calculate simply all the number of QRS complexes in rhythm strip and multiply by 6. So in that case, we can neglify which is one is smaller or there is a larger RR interval. So for irregular rate, that works very well. But the rhythm, that should be very standard rhythm strip should be there.
Yeah.
Yes,
So
Yes,
once
sir, that's quite correct.
sorry.
Absolutely.
I pulled up one ECG just because sir has mentioned this point, ECG is not only about the heart. Now, this, I will give you a clinical background. This is the ECG of a newborn, okay? This is a baby who was just 3 days old and I was called in because this child had VT. So I want you to interpret this ECG systematically and tell me whether this child has VT or not.
No.
There's only one answer, no P wave.
Okay. So again, this is the reason why I want you to systematically interpret every ECG. Okay. So what is the heart rate here? You can very clearly see it is 2 large squares, right? Consistently, it is 2 large squares. So the heart rate is only 150 per minute. So is 150 per minute a normal heart rate or tachycardia in a newborn? So it's actually a normal heart rate. This child does not have tachycardia at all. This ECG was actually because of a electrolyte abnormality and not because of a tachyarrhythmia per se. Okay. So as I brought it up just because I brought up this point about rhythm ECG being more than just heart diseases. So before you jump to diagnosing VT, it is ventricular tachycardia. So there has to be tachycardia to start with. Okay.
Yes, that's right. Are we going to have a follow-up talk on the arrhythmias in the next session?
Yes, sir. That will be, means it is alternate Sunday. So next to next Sunday, it will be on arrhythmia.
I think that will be of much greater benefit because they can then practice what they have learned today on their arrhythmias. But that's where it will be the most useful. Um, that'll be
Yeah.
next to next Sunday. That'll be on 7th of
Yeah.
December.
Right. Yes.
30th is the next Sunday. Then the
Right.
7th
7th.
December will be the next Sunday. Dr. Mani, we will be talking about that.
I
No.
think Dr. Atul is doing it, I think.
How frequent do you find arrhythmias in the regular pediatric cardiology practice, especially the inherited arrhythmias which you are so passionate about?
Sir, actually, that's what I had this talk. Like, when I was a trainee in Amrita between 2013 to 2015, we had only suspected inherited arrhythmias in 2 patients.
Okay.
But then when I came back after my training in Australia and joined as an assistant professor there, so same place, same referral population, population of Kerala didn't change much. Between 2018 to 2020, we had 14 families with inherited arrhythmias, all of which were proven. Okay, so I think it is a case of the eyes don't see what the mind doesn't know. So
Yes.
the incidence of inherited arrhythmias is the same worldwide. It's roughly around
Right.
1 in 10,000. So, and
It's only when you start looking for them, yes,
yeah, you'll be there.
they'll be there. Because also it's very challenging and very fascinating also to
Yeah.
diagnose arrhythmia, especially the inherited ones. It's very fascinating.
And
That's
the great thing about it is that these are conditions where the risk of sudden death is very high,
exactly.
but most of them can be treated by very simple maneuvers. So, especially the common ones, all it needs is, a beta blocker, which is going to cost 10 rupees or 15 rupees per day. And that can almost totally remove the risk of sudden death.
One thing I would like to emphasize upon is that an ECG machine should be a part of the pediatric intensive care unit because quite often it is borrowed from the adult ICU or from some other department. And if it is there, and if we start using them much more frequently in our regular clinical management, uh, our residents will learn them faster and they become masters at interpreting the ECG, which will stand them good stead in the regular practice, not only in the intensive care unit. So that orientation will develop and they will develop that proficiency, which will be of great use in their regular clinical practice, even later on in their lives. So,
So
an EKG machine is not very expensive. I think a regular machine would cost how much um,
it's
around a
around,
lakh?
yeah, not very costly thing.
Not very
1
costly.
lakh, 1 lakh, you'll get a very good machine, like in GE or Flo.
In between you can
But
get.
a reasonably good machine, I'm sure you can get 50,000 or something like that.
So if it is there, I think it will be useful for so many other purposes. Apart from diagnosing the congenital or cardiac lesions, a non-cardiac lesion can also be very easily picked up, especially monitoring. We have get so many patients now with diabetic ketoacidosis, where cardiac monitoring is crucial, and other such metabolic syndromes and diseases. So an EKG machine should become a part of the pediatric intensive care units. So I think that's one fact
So
we would like to
even
emphasize
if
upon.
you don't have one in a ICU, I'm sure most ICUs will have a defibrillator. So you can always, connect the leads from the defibrillator and take a printout of the rhythm from the defibrillator. It will give you only one lead, but at least that is better than nothing.
Yes, definitely right. I think some smartphones have that developed that capability of
Yeah, yeah. There are apps
recording.
available, and there are apps available. Like smartwatches, yes, you can get even 12 lead ECGs nowadays. And even for smartphones, there are some app available which are with a very small. They are actually not very expensive as well. So there's just a add-on tool which you can connect, keep it in the chest, and you can get a 3 lead ECG.
Yeah, yeah,
They're not very expensive. So as a pediatrician, you can buy and keep it in your practice. No?
yeah. I think that'll be useful. Yeah, if you can put the names of some of these apps in the chat box, that'll be of great use
But
because everyone has a smartphone, and with an app, especially for older children, that can be quite effectively managed. Quite
so I've
effectively.
forgotten what I'll do is I'll find out, and then Munish ma'am, she can share it with
Yeah,
everyone.
yeah. She can
Because
put in
we
the.
have ECG machines, like we don't unfortunately look into it. But there's a very good app. I've actually tried it out for the company, and they gave it. I'll just, I'll send it to you, sir, definitely.
Sure, sure.
So, thank you.
Dr. Mradal, any more comments from Dr. Mradal?
No, no, I'm good, man.
Yeah.
So thank you, sir. Thank you, Mani. Thank you, Mridul. Thank you, sir. And thank you all the attendees. Dr. Om Prakash is there. Dr. Vikas also joined from Aligarh. Dr. Vikas is very regular. He always join our webinar.
Manazir sir is also there. Dr. Manazir Ali from Aligarh Medical College,
Yes,
Head
sir.
Department.
Sir,
Yes, yes.
yeah, I feel so good. Sir always join. Means this post-lunch session, e-learning activity, sir is there. So it's his passion to learn. It's going on. So we have to learn a lot from sir to spend time for these activities. And thank you, sir, for being here. And
Thank you very much for learning a lot.
thank you,
Thank
sir.
you very much.
Great pleasure
And
having you, sir. Great pleasure.
Yes.
Sir is all in the front of academics,
yes.
always teaching.
Yes.
Dr. Mani, thank you so much for that wonderful talk
Thank you,
and
sir.
making
Thank
it
you,
so
Munish ma'am.
simple and so easy to remember, especially. Really.
Thank you all. Thank you, UPIP, and thank you, everybody. Have a good day. Thank you. Bye.
Okay, bye.
Bye.
Thank you.